Welcome to Chapter 8, covering exercise for impaired balance. Balance, as it relates to postural stability, is a dynamic process to maintain the body's position in equilibrium. Postural orientation is the ability to maintain alignment of our body segments, and postural control means having control of a body position in space to maintain orientation and stability, so not only aligned but also stable. It would be unlikely to move if an outside force acted upon it. We should be familiar with these first two terms here, but our center of mass is the point at which the body is in perfect equilibrium and it lies slightly anterior to S2, just behind the navel. Our center of gravity is the line that points in the direction of gravity, running straight through our center of mass to the ground. Momentum is the product of mass times velocity and is an important concept in balance because it can be what helps us to maintain our balance or lose our balance. And various situations, depending on, thinking of going to lift up a box from the ground. If you think that that box has weight in it and it's empty, you go to lift it up, your momentum can take you backwards for that loss of balance. Whereas we've had times where we're thrown off balance and we use momentum. You can think of like swinging your arms in the air to try to catch it, where you use momentum to maintain balance. So it's an important concept here. I want you to pause for a minute and think about how carrying an object affects a person's center of mass and how an amputation would affect a person's center of mass. Write down your thoughts to this and bring your answers to class in case you're called on to answer the question. Our base of support is the perimeter of the contact areas between the body and its supporting surface. So if we are just standing, it's the border outlining our feet. But if we're standing with an assistive device, it's the border outlining our feet and then the assistive device, and therefore our base of support gets bigger. Our limits of stability are the sway boundaries that our body can move in to maintain equilibrium without having to change the base of support. If you stand up right now and close your eyes, you can probably feel your body sway, but as long as you don't need to take a step to maintain balance, that sway is occurring within your limits of stability. Figure 8.1 in your textbook illustrates the boundaries of the limits of stability while standing, walking, and sitting, and can be helpful to look at for my visual learners. Ground reaction force is the response to Newton's law of reaction, and so while gravity points down through our center of mass towards the ground reaction force points exactly opposite through our center of mass, pointing up, having forces acting in equilibrium. Our center of pressure is the location of the vertical projection of the ground reaction force and is likely in the same location as our center of gravity. Now that we understand all of these terms, it's important to understand that balance requires physiological system interaction, and it's not a process controlled by a singular system of our body. We have to have controlled interaction of our neurologic systems, musculoskeletal, vestibular, and cardiovascular systems. We also need to consider the impact of environmental factors such as physical surroundings, support surfaces, the effects of gravity forces, and footwear. That's why we always educate our patients to wear shoes when they age as their balance declines, so that way the shoes have the support needed to maintain balance. We also want to consider how cognitive and psychological factors can influence balance to be able to address the patient as a whole. Figure 8.2 illustrates interactions of personal factors, environmental factors, and task characteristics for balance control, and may be worth familiarizing yourself with. Our sensory systems that have to be integrated to maintain balance include our visual system, our somatosensory system, which perceives things related to touch, and our vestibular system, which works to determine how our head and body move in space in order to maintain balance. Balance requires integration of all three of these systems, otherwise balance deficits present. If we have a deficit in one system, another system will often kick in to compensate and avoid those balance deficits. These coordinated systems have to work to respond to balance disturbances or external forces in order to make the appropriate corrections. The central nervous system fires in the order of stretch reflexes, so think about those quick corrections to balance that we don't think about but happens because of stimulation to the muscle spindles. They often don't require a change in position but a change in muscle activation, and so that's outside of our conscious control. Then we have the automatic postural reactions where we shift our posture without conscious control that can kind of be anticipatory, and then we have our voluntary responses. So we can see that a lot of our balance control happens at a subconscious level, is not something that we can be in conscious control of. Clinically, we work to improve balance by challenging the balance system. We typically are going to challenge the area where the patient has gone towards the weakest part of their balance, or they have the greatest deficit, in order to create improvement with the task. But if a patient's deficit is so large that we have to rely on those other systems, we'll challenge the other systems more in order to refine their response. If we want to challenge the vestibular and somatosensory systems, we take away the visual system and have the patient close their eyes. If we want to challenge the vestibular and visual systems, we can put the patient on a foam pad to decrease the reliance on the information from their somatosensory system. Because the vestibular system is wired into our inner ears, it's hard to remove that system from contributing to balance, but we can add things like perturbations and head turns to more specifically target the vestibular system. So if you want to pause again and think about what modifications could be made to static standing to pose the biggest challenge to the vestibular system, write your answers down and then bring them to class to discuss. We have three naturally existing types of balance control. Steady state control is the control used in order to hold a static position. Reactive control is what kicks in when reacting to an external or even internal force. And then anticipatory control is control that kicks in before an external or internal force acts upon the body's system in anticipation of that force. So it's kind of preparatory. They're very nicely named because I think that they tell you what they do. Reactive, meaning they react. Anticipatory, meaning they anticipate. And then we have adaptive control, which is a type of control that we can develop because it's an improvement of balance control as a response to practice. Our closed loop balance control is more associated with reactive control and requires precision movements, whereas our open loop is associated with anticipatory control for fast proactive movements. When we talk about balance, we have to discuss the difference between static and dynamic balance. Static balance is when the body is staying still, and dynamic balance is when the body is moving. So we can see here that there's minimal movement with static balance, and we can assess static balance with tests such as the single leg stance, parts of the Berg balance test, the Romberg test, and a postural sway assessment. Dynamic control involves movement of the body and can be assessed with tests such as the timed up and go, the functional reach test, the 4-square step test, and the Y balance test. We will go over some of these in class as part of your lab, so you can be familiar with them, but I would understand this slide to be confident in your understanding of the difference between static and dynamic balance. When we have a disturbance to balance, we have recovery strategies used by the body in order to maintain balance. And the very first of those to kick in will be our ankle strategies, where we have distal to proximal muscle activation in response to small perturbations. When a patient has a small anterior displacement, we'll see the ankle strategies kick in with posterior muscle activation to correct the anterior displacement. This also works in reverse for a posterior displacement, so we would see anterior muscle activation there. Hip strategies respond to perturbations that require more balance control than what the ankle strategies can provide and kick in second. With hip strategies, we see a proximal to distal muscle activation with anterior displacement causing posterior muscle activation, or muscle action rather, to correct, and then vice versa. So if we have a posterior displacement, we would have anterior muscle action. Hip strategies cannot be used when walking on a slippery surface because of the horizontal forces, and that's part of why we have decreased balance on slippery surfaces, because we've lost one of our strategies. If you want to test these, you can stand facing forward on a skateboard and have someone provide a small displacement either forward or backwards. A backwards movement on the skateboard will cause anterior displacement of your body, which should engage your plantar flexors to correct a small perturbation, and your lumbar extensors and glutes to correct a larger movement. You can check out figure 8.3 in your textbook to see how these strategies are used to control body sway, and box 8.1 contains factors influencing the selection of balance strategies, which can be helpful for you clinically. We also have weight shift strategies, which are going to happen in the lateral plane. So they're used when our perturbations are experienced side to side, and the hips are the main moving area to adjust for balance. And so it's really, again, a matter of weight shifting because that's the strategy's name. Suspension strategies are going to result in a rapid lowering of the center of gravity so that the person assumes kind of this crouched position. If you've ever been standing on a bus when it started moving, you might have engaged in a suspension strategy by flexing your hips and knees, and you end up in a dorsiflexed position at the ankle because you've quickly lowered your center of gravity, gotten into this more squatted position in order to be prepared for whatever happens next. Suspension strategies are kind of that forced athletic position. And then we have stepping strategies, or what we end up relying on when our hip and ankle strategies aren't enough to maintain balance. So the person will be forced to take a step to increase their base of support and not let the center of gravity fall outside of the base of support. So our ankle and hip strategies work to correct movements of our center of mass or center of gravity to stay within the base of support. When our ankle and hip strategies aren't enough to keep that within the base of support, we will take a step to increase that base. While we talk about the different instances in which these are used and the order in that they're activated, it is important that we have ankle strategies, then hip strategies, and then stepping strategies. The reality of the situation is most of our balance responses are a combination of all of these different strategies. All right, question time. A PTA observes a patient utilize a suspensory strategy to regain their balance. Which active movement would be most characteristic of this postural sway? Trunk extension, hip extension, knee flexion, or ankle plantar flexion? Pause now. The answer is C, knee flexion. So knee flexion is often the immediate action utilized in standing to lower of the center of gravity following a significant perturbation. This action often provides the individual with the ability to regain their balance. Next question. Which of the following components of balance would be most impacted by a patient using the suspensory strategy to control their balance? Line of gravity, center of mass, base of support, or limits of stability? Pause now. And the answer is B, center of mass. The center of mass refers to the point that corresponds to the center of the total body mass. This point is where the body is in perfect equilibrium. The center of mass would be dramatically lowered using the suspensory strategy as the body assumes a crouching or squatting position. So diving back into the content, it's important to understand balance under varying conditions because that is how we know what interventions to select when our patient has a balance deficit. During quiet stance, the body is swaying back and forth about the ankles, and so we see activation of our ankle strategies to maintain balance during quiet stance. We also have activation of our glute med, TFL, iliopsoas, paraspinal, and intermittent abdominal activation to help maintain full body balance during quiet stance. When perturbations or forces are applied, either internal or external, we need to move to more of the higher level strategies depending on how large that perturbation is. The best or most effective balance responses to perturbation include anticipatory postural adjustments, where the whole body is able to shift postures in preparation for an internal or external perturbation. You can think of these like the weight shift you do before you take a step. You're taking a step with a leg for walking is going to be an internal perturbation. And so your body makes the anticipatory postural adjustment by shifting your weight over to the stance leg prior to taking a step in order to maintain balance. We can also look at balance during whole body lifting. Figure 8.5 illustrates a postural adjustment for lifting a heavy load versus a light load to give you a visual representation of what we can see, but we see both have a center of mass shift towards the object that we are lifting. Hint, hint, in case you didn't answer the question earlier, that's the answer. So our patient has to have an anticipated weight shift and use of momentum to lift the object. Again, you remember going back to the empty box scenario I described earlier. That's why we can have an increased fall risk if there's any kind of uncertainty or confusion about a weight being lifted. Because if we don't know how much force to generate, momentum can throw us into a posterior direction that can result in a fall. Lifting style is also important. So while bending the knees helps to protect the back during lifting, maintaining knee extension decreases the risk of balance loss and can be an important compensation to mitigating fall risk. There are a couple of different lifting styles shown in your textbook, whether that's a staggered stance, bending with or lifting with bent knees, lifting with straight knees. I would take a look at all of those pictures to feel confident, but it's important to determine the safest lifting technique for your patient and provide them with the instructions that maximize their safety. I think those figures are 8.4, 8.6, 8.7, and 8.8 in your textbook. Balance in unperturbed human gait is where I can say that walking is just controlled falling. So you're not walking, you're just falling with style. During gait, we're constantly shifting our center of mass outside of our base support and then catching ourselves by increasing the base of support. So it's important to remember that we need to have good balance in order to have quality gait. We know we have three sensory systems contributing to balance, and when we talk about somatosensation, we have to remember that it includes light touch and proprioceptive deficits. So these deficits can occur as part of nerve injury, and they can also be a common part of aging. Excuse me. Box 8.2 contains risk factors for falls among older adults because of the impacts of aging. We need input from all three of these systems to coordinate with our motor system in order to get balanced responses. And so if we have failure of any of these systems to integrate, it can be due to damage to the basal ganglia, the cerebellum, or the supplementary motor areas, which limits how the sensory information is processed in order to generate the appropriate motor response. When there's a disconnect in this processing, the body's often going to develop an increased reliance on one of the sensory systems to decrease that level of processing that's required, so the brain doesn't have to think as much. This compensation can help in the short term for balance deficits, but it needs to be corrected in the long term for maintaining good balance and limiting fall risk. Other impairments can arise instead of from the processing information and generating the appropriate output, rather they just from the motor output itself, and so the sensory system may not even be involved in some of our balance deficits, and that's why it's important to do the appropriate assessments to determine what is involved. But things like poor posture, joint range of motion limitations, and decreased muscle performance can all be motor-specific base contributions to balance deficits. Neuromuscular impairments can also be more motor in nature. We can have a mix of sensory in there, but the majority of our neuromuscular are going to have motor implications. And pain, or more accurately, avoiding pain, can limit motor firing to limit motor output and therefore increase balance deficits. We've talked about how we have impacts to balance as a result of aging and its effects on the sensory system, but we can also see impacts on the motor system with delayed muscle activation and impaired anticipatory postural adjustments. Balance may also be impaired from medications that patients are taking, and this is important to remember so that you can identify patients who are at an increased fall risk as a result of their medications, whether that's protecting them in the clinic or providing them education about fall risks. So a patient who is on 4 or more medications is deemed as having polypharmacy and is at an increased risk for balance deficits. Hypnotics, sedatives, tricyclic antidepressants, tranquilizers, and antihypertensives are all commonly used and can influence balance. And any medication that affects the level of arousal for the patient, such as gabapentin or levodopa, can cause balance impairments. We have to be able to assess balance in order to know if balance deficits are present. So Table 8.2 describes balance assessments and interventions if you want to take a look at the assessments as we go through this, or need a helpful reference for any situation. We have different kinds of balance assessments because we have different kinds of balance. And so we have to assess multiple areas to make sure that we're identifying the correct thing. So we have assessments of a patient's balance that are self-reported, known as the ABC, or the Activity-Specific Balance Confidence Scale, where the patient self-reports their level of comfort or confidence with different balance activities and functional tasks. Steady-state balance tests are tests where the patient has to maintain static positions throughout the entire test. So examples of these can include the Romberg, a single leg stance, a stork stand test, and the 4-stage balance test. The ones that are starred we will perform in class and may be on your skills check or practical. Steady-state dynamic balance tests look at a patient's ability to maintain a static position after a dynamic movement. So we'll use the 5 times sit to stand in class to look at this because that requires maintaining a static balance in standing after moving from a seated to standing position and then having to transition in between those. Anticipatory postural control tests assess a patient's ability to make those proactive adjustments to maintain balance. Examples of these are going to include our functional reach test, the STAR excursion test, and the Y balance test. Reactive postural control tests don't look for how a patient can prepare to maintain balance, but rather how they can react to maintain balance. We can use the pull test or the push and release test to look at these. I can give a demonstration in class if you need, but safety-wise, they are not commonly utilized tests. Our sensory organization tests, such as the CTSIB, look at how well the body integrates information from the vestibular, visual, and somatosensory systems. We'll look at this more on the next slide. And then functional tests observe balance during functional activities. Examples of these are going to include the timed up and go, the 4-square step test, the dynamic gait test, or the functional gait assessment. These last two are going to be more specific to assessing vestibular disorders because they require head turns, with the functional gait assessment being like an updated or revised version of the dynamic gait index, and therefore it's going to be the most specific to vestibular disorders. So circling back to the CTSIB, this test looks at a person's balance in 6 different sensory conditions in order to determine the system most impacted and how that information is processed together. So the CTSIB is also known as the Fomin dome because we can use an Airex pad or foam for them to stand on, and then there is a sensory dome that helps to isolate the vestibular system. So the first scenario or condition would leave the patient with their eyes open on level ground so that all of their systems are in place. Then we take away vision so that they only have vestibular and somatosensory to rely on. Then they put on the dome, and that creates disorienting visual information. So it's not removing visual input, but it is inaccurate visual input. So there's a stronger reliance on the vestibular and somatosensory systems. Stage 4 is eyes open on a foam pad so that there's inaccurate somatosensory information and the patient has to rely on vestibular and vision. Then we remove vision so that they're still standing on the foam pad with inaccurate somatosensory information, no visual information, and then the vestibular system is relied upon. And then we leave them on the foam and then put the dome over their head so that they have inaccurate vision, inaccurate somatosensory information, and are extremely reliant on the vestibular system. These scenarios increase in difficulty and again are used to determine which system is contributing to balance deficits. Question time. So when assessing balance, which of the following activities would be the least challenging for this patient? Standing on foam with eyes closed, standing on foam with eyes open, standing on foam with eyes closed, lateral weight shifting, and activities in single leg stance. I apologize for accidentally skipping over that answer. The answer was C, lateral weight shifting, because lateral weight shifting is going to be the least challenging activity since the patient is able to rely on all of the systems that contribute to balance within a normal base of support. Moving on to the next question. A PTA prepares to assess the balance of a patient who has a neurologic condition. Which of the following methods is the most appropriate to assess the vestibular component of balance? A. Apply a perturbation to alter the body's center of gravity. B. Assess cutaneous sensation. C. Assess proprioception in a weight-bearing posture. D. Quantify visual acuity and depth perception. Pause now to answer. And the answer is A, apply a perturbation to alter the body's center of gravity, because the vestibular system reports information to the brain regarding the position and movement of the head with respect to gravity and movement. Assessment of the vestibular system often includes perturbations that require the body to make automatic adjustments that restore normal alignment. Because balance exists in different states, we have to train it in different states. So table 8.2 describes those balance assessments and interventions. We talked about the assessments, now we're going to go through the interventions, but if you'd like to make the connections, that's the table you can look at. We'll go through the different states here. So for steady state static balance control, this is all about having a patient maintain a static position, whether that's seated, kneeling, standing, whatever position you want to put them in, they need to be able to maintain balance holding that position still. We can increase the difficulty of these types of exercises by decreasing the base of support, putting the patient on a compliant surface, taking away visual inputs, increasing cognitive challenge, and eventually superimposing upper extremity movements. Steady state dynamic balance control involves maintaining balance while on a moving surface. So there's often an overlap in the progression of steady state static control to the initial steps of steady state dynamic control. So for these, we might start a patient on a seated TheraBall and have them maintain balance. We can challenge these exercises by, again, decreasing the base of support, removing visual input, adding cognitive challenges, and superimposing upper extremity movements. But we can also increase difficulty by adding whole body movements, and performing exercises in a more balanced, challenged position. Anticipatory balance control is refined by having the patient maintain posture while reaching outside of the base of support. Because the body has to anticipate the center of mass shift towards the edge of the base of support, and make corrective adjustments, we can increase the difficulty by starting the patient in a more balanced, challenged position. So maybe we start them with their center of mass closer to the edge of that base of support. Or we can add weight or variability to reaching outside of the base of support and incorporating functional elements like reaching overhead towards a cabinet, which would be a more functional reach. Reactive balance control is where we will have patients maintain balance while reacting to unexpected perturbations, and we can increase the challenge of these in a lot of the same ways we've previously discussed, always progressing towards function. With all of the types of balance control exercises, we can give a patient safety is always going to be critical, especially as we get up into higher level balance challenges. So the gait belt better be on your patient, and you can look at box 8.3 for safety during balance training. We can also target balance training by focusing instead on the state of balance, but rather the integration of information needed to maintain balance. So we can do this by replicating a lot of the conditions that are seen in the CTSIB, because those conditions alter the sensory information that the patient can rely on in order to strengthen the ones that they have left to use. So for example, if we're doing balance training with a patient's eyes closed, we're enhancing their vestibular and somatosensory systems. We can't do anything to improve the communication with their visual system when we take the eyes away, so we're leaving reliance on the other two. It's much harder to alter vestibular information, so we typically are going to alter or remove visual or somatosensory information, with vestibular being our remaining system. And so remember, we need head turns and perturbations to really challenge our vestibular system. We also want to ensure that we practice balance with our patient-specific functional tasks, including gait, and that this is where head turns can be very helpful for challenging the vestibular system related to function. Again, safety considerations can be found in box 8.3 because they are important for balance. Question time! A PTA instructs a patient to perform a squat exercise. The assistant then decides to modify the exercise by placing a Bosu ball flat side down under the patient's feet. What is the primary purpose of this modification? A. Add resistance to the exercise. B. Challenge the individual's balance. C. Add stability to the exercise. D. Challenge the individual's ankle flexibility. Pause if you need more time. The answer is B. Challenge the individual's balance, which I feel like should have been a gimme in this lecture, but standing on a Bosu ball requires greater balance as compared to standing on flat ground because a Bosu ball is going to be that compliant surface. The addition of the Bosu ball to standing exercises is primarily used to challenge a patient's balance. A patient who has a history of falls due to age-related attention deficits participates in balance training. Which of the following activities would be the most difficult for the patient to perform given the age-related attention deficits? A. Maintaining a posture while focusing on a distant object. B. Holding a specific posture while listening to music. C. Ambulating in a narrow, uncrowded hallway. D. Ambulating while performing mental arithmetic. Pause now if you need time to read. And the answer is D. Ambulating while performing mental arithmetic. Ambulating while performing a demanding activity like mental math is an example of dual tasking and challenges the older adult's attention to a greater extent. Remember, this is the type of cognitive challenge we can add. We can also experience balance deficits as a part of recovering from orthopedic conditions. And so there's evidence-based balance training programs for specific musculoskeletal conditions, with ankle sprains being one of the most commonly associated with subsequent balance deficits. And to treat balance deficits found in this, we want to use unstable surfaces to challenge proprioception and promote intrinsic muscle activation. Figure 8.25 in your textbook shows a progression of single leg stance on a Bosu ball for a patient following an ankle sprain. But we must also challenge the knee, hip, and trunk when we're doing this. So we want to educate the the ankle, and with neuro reeducation on stability and control through balance training. But we also want to make sure that we are using the knee, hip, and trunk to contribute to those things. ACL injuries, again, we need an emphasis on proprioception and incorporate plyometrics as they return to sport for that both anticipatory and reactive balance control. And then low back pain can cause deficits in postural control, and so we're going to want to start addressing balance deficits in patients with low back pain by addressing postural deficits. Alrighty, well that wraps up balance. So before you come to class, bring your answers to the open response questions from the lecture. Bring any questions that you have from the lecture so that you can be sure to ask them in class. And make sure you wear good shoes for the balance lab.